self-assessment, like what are you going through? um what are you feeling? Is it normal? I get that question a lot. Is this normal? Are my periods normal? I can't even tell. So it just helps you to kind of assess everything, your periods, like bowel, bladder, pain, like hormone type stuff, what your thoughts are on fertility, like what your goals are. So there's a chapter on that in the beginning, and at the end there's a chapter on, well, how do you get the care that you need? And it talks about not just how do you talk to your doctor, because obviously that is very important, but also to kind of decide for yourself what's important, because sometimes you only get a short time with your doctor, and it helps to like kind of have reflected before you go in there, like what are my feelings about medications, surgeries, fertility, what are my goals, what's most important to me, so that then you can kind of hit the ground running with your doctor. Part of the problem is this medical system where OBGYN practices are so slammed, like they are, like there's a lot of burnout, like people's practices are closing, the reimbursement's bad, so people are seeing like 40, 50 patients in a day, and you only have a couple of minutes with your doctor. It helps to kind of just hit the ground running with, I'm having these issues, here's my period, here are my goals, like I would like to talk about this, and just to kind of accelerate the discussion a little bit. So it may not fix the entire system. In an ideal world, you would have a lot more time and be able to kind of have a longer discussion and a more nuanced discussion, or have a doctor that already has a lot of this knowledge, so that you don't have to spend as much time trying to kind of explain yourself. So that's the ideal situation, but in sometimes these imperfect medical systems where you have limited time, at least kind of going into the visit, having kind of like learned about a lot of these things, reflected on your own experiences, like written down some notes on like, your periods, what you'd like to discuss, your questions. It just helps to kind of like make the most of your time.
I do remember when I was pregnant, I always had a list walking into the doctor's
Mm-hmm.
office because I knew like I had 10 minutes
Mm-hmm.
you know, and it was a whole new experience, right? When you're pregnant, everything is different. So I want to go back to misinformation, not like the Freudian era of
Mm-hmm.
misinformation, but our new era of
Right.
misinformation.
Nowadays,
There
social media.
there was an article recently in the Washington Post, I think, about how much misinformation there is online about the pill. The
Mm-hmm.
pill and estrogen has somehow become the
Yes.
enemy of the wellness guru and influencer. Um,
Yes.
why do you think
Yeah.
we're so anti-pill in the moment? And how can we, if I think there's a lot of sex educators on this call too,
Mm-hmm.
how can we promote the information that's accurate about the pill?
That is so important. Actually, right before this, I was just scrolling Instagram, and like some other, like I forgot what the platform was. It was like a political platform, but they were basically like they took clips of a lot of like conservative, like politicians,
Yeah.
just like saying all this crazy stuff, like, like birth control like hurts your, like it damages your brain, and like all of these things, which are like, I don't even know where they came up with some of this stuff. There's sort of an interesting cross section between the like wellness and natural like influencer space, and like the extreme conservative like anti-reproductive choice space, and they're sort of
I
like,
need
there's the
that
Venn
to
diagram where they overlap
yeah.
in birth control. Like they are just like very anti-birth control. So I will say that everyone has sort of their different, like what is the reasoning behind that? In the wellness space, it sells courses, it sells supplements. There's a lot of money to be made in like being like, well, birth control is super bad, you need to detox your body, so buy my extremely expensive like vitamin supplements, which have no data and no FDA approval and no monitoring. But they're promoted as being like, it's so natural, like you're, freeing your body of these like poisons. I was just saying, I was doing an interview with the Times earlier, and she actually had a very similar question. She was saying in terms of like childbirth, like in the wellness space, and like, you should never, ever do an epidural. You should never be on birth control. And that is actually like very like misogynistic. It's like basically like stripping choices away from women, like pain control, like, controlling your own like reproductive future. And I always kind of say the reason that these perspectives have taken off so much is because some people do have side effects with hormonal birth control. It's not like for every single person, and some people do get like, mood side effects, other, issues with birth control. So it's not to say that everyone should be on it, but to say that no one should be on it, it's always bad, it's always dangerous for you, it's, is very damaging. I always say that anything that is a side effect of birth control is like many-fold higher risk in pregnancy. Weight gain, mood symptoms, blood clots, death, much higher, like orders of magnitude higher risk in pregnancy. But whenever people look at the risk of things like birth control, they take it in a vacuum. They're like, oh, like some people have like mood symptoms. I'm like, well, but if you take them off their birth control and they have irregular cycles and they get pregnant on natural family planning, the pregnancy side effects are way, way higher. So people like very much like emphasize like the danger, danger, danger without looking at the whole thing, the big picture, the alternatives. I use the analogy of, if somebody is like has a gunshot wound and needs anesthesia to have surgery, like that would be like, oh my God, anesthesia has all these risks. You could die. You could like, have a heart attack, but they don't mention, oh, there's a good thing that happens with anesthesia. It allows you to like have this life-saving surgery. So again, whenever you talk about risks, and for all the health educators, like obviously this, I'm kind of preaching to the choir, but you don't just talk about the risks alone. You have to talk about the alternatives and also what are the risks and benefits of the alternatives. So when we talk about birth control, we have to talk about if somebody wants to do like a natural family planning, like a fertility awareness, we have to say, well, your cycles have to be regular, you have to do X, Y, and Z, like cervical mucus monitoring. Like it's not just magically you're not going to get pregnant. There's a lot that goes into that to make it at all, a significant effectiveness. So you have to kind of like every single thing without this bias talk about the risks and benefits. And I think for us as educators, to know the fears that people are coming into it and just kind of to acknowledge and address those fears and to help to make it so that we're finding the right answer for that person. So rather than being so extreme, like you should always do this, you should never do this, be like, you are a person with a particular set of perspectives, health risks of your own. Like some people have higher risk of blood clots or breast cancer, other people's don't. So we have to look at you as an individual and help you find the right thing for you. So that's how I frame it when I talk to patients, and especially if they come in with a lot of concerns about the risks of birth control. Like for instance, a lot of people come in being like, well, I have, grandmother had breast cancer, I don't think I should ever take hormonal birth control. And then you can kind of educate about what the actual risk is, the relative risk of things, and go from there.
So
But
we have
yeah,
a
it is very, it's the thing right now is very like
be
birth
critical
control
of
is
birth
evil,
control.
no one should take it. And right as all of the abortion laws and all of like the criminalization of abortion, it's going to leave people,
Without any
one,
options.
pregnant, and what do you do then? So yeah, it's quite a horrible collision of different things
And I
happening.
think, in some ways you're right, though. It's not exactly a coincidence. We do have it coming from both sides, but it's not exactly a coincidence. And it has a little bit of a misogynistic bent in there.
Absolutely.
And I just, when I had to take a childbirth class, I very specifically signed up for one that was for people who wanted an epidural because I did not want to be talked out of it.
Yeah.
As they invented pain medication for a reason, and I'm going to use it. And I
Yeah.
did, and I had two pretty uneventful, thankfully lucky, pretty easy childbirth experiences. So speaking of pain management, this is really funny. We have a question in the chat, which was literally, I want to hold this up just so that I'm for
Mhm.
proof. The
Yeah.
next question I was going to ask
Yeah.
is one of the other things that's gotten a lot of attention now is
Mhm.
about pain for IUD insertion.
Yeah.
And I think what people have been saying online and is really true is a lot of doctors really play it down,
Mhm.
right? This goes back to the not being believed, not
Yeah.
being dismissed. And a lot of doctors are like, it's going to hurt for a second and you're going to be fine,
Mhm.
and don't offer any pain management.
Yeah.
And um, so the two questions we have for you
Mhm.
is a little bit of why do you think that is, but more
Mhm.
importantly, what can we ask for
Yeah.
in terms of pain management?
Yeah, and this is something that actually, for all of the ills of social media, that has actually been kind of a positive thing in
Yeah, Planned
that
Parenthood was
it's really
active.
led to more of a discussion about pain management and pain treatment options for IUD insertions and other like procedures. Now, I will have the caveat that like maybe like 2, 3 years ago, there was such an uproar that I kind of got dragged into it and slandered a little bit in the midst of all the frustration. So I made a video. There's so many videos at the time, like just saying like, oh, gynecologists are evil and they're torturing women and like this is so horrible. And being evidence based, I tried to, there was one video specifically about the tenaculum, which is the instrument that's used to hold the cervix. I was just addressing the tenaculum because that's all they were talking about. They showed the instrument. And I was saying, like, there's been several studies that show that there's not a significant benefit to local anesthetic. Like numbing medicine doesn't actually really help with that, because it's also a needle. It's like the tenaculum is a pinch and the needle is a pinch. And when you look at studies, there's no difference in kind of pain experience. People clipped that out of context and said I was saying that IUDs don't hurt.
Oof.
I did not say that. I didn't even say the word IUD in this video. And actually, later on in the video, I actually put on the screen, actually, there is evidence about local anesthetic and IUD insertion. So that's the only thing I said was like, it can help with IUD insertions. Like somebody slandered me, like put me in this viral video. There's like, doctors are horrible. Like they say IUDs don't hurt. And I literally got so many hate messages. Like I didn't even say that. But just to say, if anybody out there is watching this, I do put the caveat there because people are like, that's the doctor who says IUDs don't hurt. And I'm like, I've never said that ever. So just like to preface with that. And as a pain specialist, I obviously talk with patients about different pain control methods. The tricky thing is that it is hard to completely get rid of all of the pain of IUDs because, there's different nerves that, affect like the top of the uterus versus the cervix. And so, it's hard to give someone medication that kind of like, addresses all of it, but we do try to. So I will say that obviously for people who have had a vaginal delivery, who are getting it placed like after they've had a baby, they're at their postpartum visit is very, very different in terms of pain experience than someone who's, a teenager who maybe hasn't been sexually active before, has never been pregnant before. The experience is different for every single person. So some people can feel very little. In fact, I actually, when I had them placed, I actually didn't feel anything because I had just had a baby and a baby came out. And so it was not, much to kind of get the idea in. But people have sometimes excruciating pain. Like they can have like almost like childbirth, like pain with IUD insertions. And so I think it's important. And what this has prompted is having more of a discussion with the patient before it's happening. Because a lot of times doctors, and the way I trained was just like, just see what happens. And if they're having pain, then you can like pivot, maybe give them local anesthetic after, but at that point they've already had pain. So I think, a good discussion that's happened because of this is to talk before the placement and make a plan with the patient. I actually have always just examined the patient before, like on a different visit. I take like a little pat brush. I just kind of see how sensitive the cervix is just when I do kind of a quick like touch of the cervix. For people who have more discomfort with just kind of a basic exam, I'm talking about things like, Xanax or like sedation, local anesthetic, like all these different options, as opposed to somebody who like, really can't feel anything, like they probably will be okay. We would talk about ibuprofen. There's a medicine to kind of help open the cervix that softens it and opens it a little bit. And some cool things that have actually happened recently that I would like to try. I haven't tried this yet, but a lot of people have said it works. Is even just doing like numbing gel, like a local anesthetic gel that they insert into the cervix, or a liquid local anesthetic that they just kind of take a little straw and put it into the uterus through the cervix without even using needles. Because again, the problem with the local anesthetic shots is that it hurts too. Like you're putting injections and that's almost
I'm
as
thinking
painful.
about going to the dentist, right? Like
Exactly.
they
It's
do
just
a
like
little
the
numbing
dentist
gel
where they
before
give,
they do the
yeah.
shot. But
And
so
that's why in the past, like people were like, well, it's not worth giving local anesthetic because it's just going to hurt as much. But now people are being creative and thinking about, well, if that's going to hurt, what can we do instead? And like, doing these things like the gel, the local anesthetic, just kind of put in as a liquid. What's it called? Like hurricane spray, which is like a spray. And then also a lot of nitrous oxide being used. I'm actually getting that in my office too, just like at the dentist's office, like getting like laughing gas for nitrous oxide. It's not great for pain control. I will say in the studies, it's not like an amazingly effective anesthetic, but the whole experience is much more comfortable. So like people do feel more comfortable getting some nitrous oxide. So a lot of gynecologists are doing that now. I actually belong to several discussion groups, and tons of gynecologists are getting nitrous oxide for their offices. So it's actually really exciting to see that, people are listening, they're trying to kind of, like improve the experience for patients because it is
I think some
important.
of it,
Yeah.
and some of it is the anxiety, right? When you
Yeah.
think things, like I'm someone who would get 7 pap smears a year if I never had to go to the dentist, right? Like I cannot stand going to the dentist. But and part of it is just because how nervous I get going to the
Mhm.
dentist. And
Yeah.
my children have always had nitrous oxide whenever they've gotten a filling, and
Mhm.
they don't have the same kind of tensed up experience that I
Yeah.
have. So
Mhm.
so people can ask for that, people can ask for sedation,
Yeah.
but the real answer is have a conversation before.
Exactly. It's so important just to kind of like to talk about what your options are, like what are the pluses and minuses. And sometimes people who truly like it's rare that we have to do it under like, like sedation in an operating room. But there are some times that that's the case. Like people are like, I really need an IUD. I cannot tolerate an insertion like in the office. I just can't. I have a history of trauma, et cetera. And so there are times that we do that. The tricky thing is then you start having system issues in that insurance has stopped paying for that. So I used to do that all the time, and then insurance stopped covering it because it's expensive. Any sort of operating room or hospital facility, treatment of any sort is expensive. So insurance is caught on and stopped covering it. And so sometimes people are like paying out of pocket for that. It's really rough. So a lot of times people get very frustrated with the lack of pain control. And I will say, like, sometimes it is just the gynecologist not having a great conversation about it, but sometimes it is unfortunately a system issue too, in what insurance considers important enough to pay for. There's a lot of that in women's health that they don't think a lot of things are important enough to pay for. So that is something that hopefully we'll get some better advocacy to, and hopefully change that.
Right.
Yeah.
Well, I want to change gears a little bit because
Yeah.
we're kind of at that our halfway point,
Mm-hmm.
and I want to start asking you the questions that people submitted when they
Great. Yeah.
registered, and this would be a great time for people to put something in the Q&A if they have a new question.
Mm-hmm.
Before I answer this, I want to do the kind of standard online interview with the doctor disclaimer, which is
Yes.
that Dr. Tang is giving us her kind of best medical opinion, but it's not her specific medical opinion about either, your case or your aunt's case or your mother's case or your best friend, whoever you're asking about, because she hasn't examined them and she can't give real individual medical advice in this forum.
Perfect.
So definitely ask your doctor or forward that person to a healthcare provider. But in the meantime, she can tell us a lot based on her experience. Um, and I think a lot of conversations right now are about menopause.
Mm-hmm.
I would like to join all of them because I'm of an age.
Mm-hmm.
Um, so the kind of overall question, the first one is what are the biggest misconceptions about menopause? But the next one is how do you prepare yourself for it? So kind of in the big picture and then in
Mm-hmm.
the personal picture.
Yeah. So, I mean, there's a lot to discuss, obviously. I keep saying menopause is having a moment because,
It really
women of our
is.
generation are just like not going to stay quiet about it. You got your Oprahs and Halle Berrys and everybody who, Drew Barrymore, who are like, this is crazy. Like, why have women not spoken? And women have spoken, but probably maybe they felt like embarrassed or they felt like they shouldn't be talking about these things or complaining about menopause. But now, cat's out of the bag. We're going to be talking about it. And that's great. I think, half of the human population is going to go through menopause. That's just a fact. And the fact that it is something that like needs to like have a moment instead of being something that we've all like kind of known about forever is a little wild. um Jen Gunter has a great analogy in that, we all learn about puberty when we were in school and you're getting like basic sex ed, but we don't learn about, well, some of us learn
Not
about
all of us
puberty.
anymore, but yes.
A few of us learned about puberty in school. But we should also learn about menopause because it's just, again, it's like a phase of life that everyone's going to go through. So misinformation, there's a lot to kind of say about misinformation. One of it is that you have to suffer because it's natural. Again, there's sort of like this verbiage of it's natural, it's a part of life. Like, you just
Pain
have to deal with
relief.
it. Women have always had to deal with it. Like, that's not true. Like, I always tell people, even if something is common, it's not normal to have to suffer with it. So if you are, having your quality of life affected, your ability to sleep or function or work or have sex or do the things that you want to do in your life, you don't have to keep on tolerating just because it's quote unquote like natural. And in terms of hormone replacement therapy, same thing. Hormone replacement therapy can like be amazing for people. Like people's lives are transformed by it. But again, there's a lot of this like, oh, it's unnatural, like hormones are bad. Obviously there's some risks. So again, this is where you would talk with your own doctor about the risks, your own health profile, the alternatives. But in general, the hormones got a lot of sort of like bad like rap because of, you know, the Women's Health Initiative, which I wrote an article recently for CNN just kind of saying that here are the ways that that study, you know, really scared people off of hormones for decades. And then when they kind of like sub-analyzed the data for like younger women in their 40s and 50s, they saw that it really wasn't as bad as they had thought it was. So the scare factor of the dangers of hormones, I think, was really overhyped. In contrast with, again, same idea, like they didn't similarly focus on what are the potential benefits. So again, hormone replacement therapy, not for everyone. There are some people who shouldn't take it if they've had a history of blood clot, you know, if they personally had breast cancer, you know, so there are obviously individual nuances, but in general, like a lot of people were like, you know, I was doing great with it. And then they told me to stop it because I was going to get breast cancer, you know. 20 years later, it turns out that that risk was a little bit overblown. And so, you know, have a conversation with your doctor, learn about the actual risks, think about the alternatives, and, you know, make the decision that's right for you. So, you know, whatever that decision is, there's going to be something that can hopefully help you with your symptoms. Um, and then you know, I had a thought and it just sort of escaped me, but what was the second part of your question? So you said like misinformation or myths.
And what do we do to prepare ourselves for
Oh, to
menopause?
prepare yourself, yes.
Because as you said, half
So
of us are going to do it, right?
right, exactly. And so I mean, just having a conversation again about, you know, keeping as healthy as possible. So in general, we start thinking about bone health, you know, as you are in perimenopause, menopause, you know, the rate of like bone loss accelerates. So, you know, things like calcium, vitamin D intake, making sure you're getting adequate intake, you know, either through a dietary source or through, you know, supplement if you need it, especially if you're vitamin D deficient. Making sure you're exercising both for heart health, you know, protecting your heart because cardiovascular disease risk increases as you go through the transition. You know, making sure that you're, you know, doing some sort of strength training because we start to lose muscle mass, and that's important to, you know, keep strong as you know, go into menopause. And weight bearing exercise, which is like walking or running, again for bone health. So these are all things that, like, you know, just like basic, just keep yourself healthy kind of things. And then in terms of just kind of being on the lookout for stuff that could be the signs of perimenopause, menopause, obviously like hot flashes, night sweats, mood swings, sleep disturbance. That's a big one that people might not necessarily realize are perimenopause. And also like sexual dysfunction. So like lack of libido, starting to have pain with sex, dryness, and then bladder symptoms. So like urgency, frequency, having to get up at night to go to the bathroom. That's actually all part of menopause too. A lot of people don't talk about that. It's not as well known as like the hot flashes part. So the vaginal and genital urinary parts we call the genital urinary syndrome of menopause, GSM. So not just that you might have some dryness, but also you might have some bladder changes as well. So just to know that, you know, kind of getting on top of those symptoms on the earlier side rather than waiting and feeling like you have to have suffered a certain amount before you get treatment for it. I always believe in kind of addressing things preventatively, like a lot of, I'm sure, people in the audience, preventative care is really important. So kind of just like being aware, like raising awareness, you know, like early treatment, so that it doesn't get to be that you're having like, you know, horrible, like, you know, vaginal narrowing pain, you can't have sex. You want to address things on the sooner side if you can.
So we have a question in the Q&A that kind of relates to something else I was about to ask you.
Mhm.
But there's a lot of talk online and in basically, you say menopause is having a moment.
Mhm.
One of the reasons menopause is having a moment is that there are a lot of people who've decided that they can profit off of menopause.
Yes. Yeah.
Right. And so there's a lot of people who are selling things.
Yep.
Our question online, somebody said the new body sprays that people are
Yeah.
selling in case your bits stink.
Yeah.
I have always said vulvas should smell like vulvas.
Yeah.
So not
They don't
I
need to
had
smell like flowers. Yeah.
a
So that, yeah, I was just saying there's almost like two separate questions. Yeah. Mhm.
yeah.
Yeah.
So one question that I have is about hormones. If you're not going through menopause,
Mhm.
or when should you get your hormones checked? Should you ever get your hormones checked?
Right.
There are
So
all these companies that promise to do it for you. Are they legit?
Yeah. So we generally say it's not actually super helpful to check your hormones if you're a certain age. So if you are like solidly like, 50, like, like late 40s and you're starting to skip periods, you're having hot flashes, what we treat is how you feel. It's not like a number, like your hormone number. So a lot of the earlier question about like the profiting off of menopause, there
Right.
is a lot of industries that have sort of popped up again, sort of more of this like it's natural, like blah blah blah, and they charge a lot of money for like saliva tests, Dutch tests, like crazy like panels of like all these things, and it's not actually useful. So actually, like ACOG, NAMS, like all of the different like menopause experts are like, well, that number doesn't actually change what we do with you. Like if and hormones fluctuate from moment to moment, day to day. So if you check it now versus tonight versus like 3 days from now, it could be completely different. So one number in the absence of like everything else doesn't actually change what we do. Whereas you'll see people being like, I had to get like 80 million blood tests, and then they like adjusted my hormones by like making this like special cocktail of hormones.
Right.
That's a little bit of BS. It's basically a moneymaker, I will just say. So because they charge for the labs, they charge for the special like compounded hormones, and just for safety purposes, compounded hormones, like there's no safety regulation for those. Like it's not like the FDA where they have to like go through very strict scrutiny and say that there's this actual amount, we know that this much is absorbed, there's the safety profile. Like there's none of that, there's no regulation. So it's actually quite like unsafe in a lot of ways, because you don't know what you're getting. Like they can tell you what they think you're getting, but you don't know like what you're absorbing. And so what's especially dangerous, I will say, is those pellets, like the pellets that are not meant to be removed. You just place them in, they can't take them out. So people have gotten like uterine cancer from them because they didn't, they had
I don't,
estrogen but
I'm
not
not
enough
familiar with.
progesterone, which prevents uterine cancer. So people get uterine cancer from those hormone pellets, or they put testosterone in there and they have like the voice deepening and like really bad like masculinization, and then you can't take it out. So yeah, those are very scary.
I had no
So in
idea that that was
general,
a thing.
yeah, like the hormone testing is only, back to your question about the hormone testing, it's only helpful if someone is young, like kind of like early 40s 30s, where we're like, is it perimenopause, or is it your thyroid, or is it PCOS, is it some other hormone issue that could be causing you to have those symptoms? Then it is important to check, because we need to kind of make sure that it is actually perimenopause or early, premature menopause, and not some other condition.
We
um
actually did
yeah,
get one question from someone
yeah,
who said they were
yeah.
36
Mhm.
and having horrible night sweats right before their period.
Yes,
So that's a situation where
that
you,
is something helpful. Yeah, we would definitely want to check hormones for that, and for that person. And then in terms of like the smelling of the like bits,
yes,
you
we were
don't
going to get
need
back to the
it.
smelly
Like I
bit.
always tell people, like it is a little bit sad to kind of tell women that like your genitals smell too bad, so you should mask it with the smell of like fruit. And so I don't think that there's a similar product for men. I mean, if there is, I don't know, but like I've never heard of a similar product for men's genitals, I'll just say. Whereas there's a whole industry to make women's like
Absolutely.
genitals smell better and more like feminine, like so, and those have risk, like they can be irritating, like the scents, like the fragrances can be very irritating to vulvar skin. So we tell people just wash with water, that's all you need. And if you need soap, use like a fragrance free soap, and that's all you really need. And so yeah, again, there's sort of like this idea of profiting off of people's insecurities, and both in terms of menopause, where people are like, I just want to do the right thing, I want to have what's best for my body. And people are really good at marketing, they're like, this is the answer, no one else has the answer except me and my like special
Smell.
concoction of vitamins and hormones that no one else has. Again, if someone's promising to be the only one who knows something, again, they're probably not the only one who knows something. Like all of the experts who have spent their whole lives researching this and looking at every available bit of information probably know at least a little bit of something more. They may not know everything either, but anyone again who promises to know everything and the whole world is dumb and doesn't know, then just don't believe them.
All right. So we have a question. We're going to stick with women over 40 for a second, but then
Mm-hmm.
there's a couple of questions for teenagers. Um, weak pelvic floor muscles
Yes.
may be a problem for, I know that they can be a problem for urinary incontinence. Can they be a
Mhm.
problem for libido as well?
They can be a problem for a lot of things. So, in terms of sex, they can cause problems with painful sex, which can obviously decrease libido for sure. So, pelvic floor issues are can affect anybody of any age. So, just to say, it's not just people who are postmenopausal. Anyone who's been pregnant, even if you didn't give birth vaginally, the stresses of pregnancy can weaken your pelvic floor. And then also people you wouldn't expect, but athletes, runners, gymnasts, people who do spin classes, people whose jobs require like heavy lifting. All of those people can have problems with their pelvic floor because they're just muscles. It's just anything you can imagine that could like cause your back muscles to seize up or be painful or like not function super well. It's the same thing for the pelvic floor. So anytime someone comes to see me for pain with sex, for example, I almost always find something related to pelvic floor, and that can be helped with pelvic physical therapy. And again, the classic things for people who think about like pregnancy and childbirth is if they're like leaking urine after, like you cough, you sneeze, you leak a little bit, or leak with exercise. If you have like a lot of urgency and you have trouble controlling your bladder, those are all potentially going to be improved with pelvic physical therapy, but also things like sex, like if it hurts when you have sex, vaginismus, like involuntary contractions of the vaginal muscles, like when people try to have sex or try and put in a tampon, physical therapists treat that. So all of these things, and a lot of people don't even know that there are muscles there. Like they might have heard of Kegels, but they don't realize like how extensive the muscles are in the pelvis. So in the book, I show the diagram. It's not just the muscles around the vagina, but it's like a whole like series, like system of muscles that goes to like your legs and your back. It goes around your rectum, like all of these things people don't even realize.
I have seen a friend of mine. So I I was recently with a group of friends about the same age, and we played a late night game of Cards Against Humanity, and
Mm-hmm.
everybody was laughing so hard. And I just want to say that I'm the only one who did not pee a little bit. It's like I feel I may have lost the game, but my pelvic floor won.
There you go.
But one of my friends was talking about this app that she has that comes with a little biofeedback. It was like
Oh,
biofeedback
cool.
on
Yeah.
her phone.
Mhm.
And I know that they used to do biofeedback with like
Yeah.
these giant machines,
Yeah.
and
Yeah.
now
Yeah.
there's a company, at least one, probably more, that offer you kind of like a tampon size biofeedback that you
Oh, that's
put.
cool. I didn't realize that they had that like for home use, but physical
Yeah.
therapists will use that for sure. It's basically a way to, because it can be really hard for people to do Kegels. They're like, what am I squeezing? I can't even tell. So it's basically a way to help you target and see that you are actually like contracting the muscles or doing the thing that you want to do. It's like a visual, like it'll either be like a sound or like a visual, like
Mhm.
sign that you're okay, you are like, squeezing, that's the right place. So they do that in some of the pelvic PT sessions. They use these biofeedback machines. I
Yeah.
didn't realize that they had them for home. That's kind of cool. That's kind of
Yeah.
neat. Yeah. Interesting.
Okay, so we're going to go to young people now.
Yeah, sure. Mhm.
And we're going to talk about PMS and PMDD. How
Oh,
do we support and educate young people who are experiencing this during menstruation, especially if they're in school while it's happening?
yeah.
And
Yeah, so PMS is very common. Like most people have some variation of PMS, which includes not just like the mood symptoms, but also like the physical symptoms, like bloating, like fatigue, breast tenderness, like that sort of thing. PMDD, for those who don't know, premenstrual dysphoric disorder is like a more extreme version of that, where there's a really significant depression and anxiety component, where it's actually affecting your quality of life. It's not just feeling like a little blue; it's like you feel really significantly depressed or very anxious. It affects your ability to function. So that can be very debilitating. PMDD can actually be extremely hard to treat because it is just a very extreme like version of like depression or anxiety. They're all interconnected. So it sometimes can take quite a bit to treat it well. And so I actually was just talking to someone the other day. It like takes a whole team, including not just like a medical team, but like support systems at home and friends and partners and parents, to kind of help people through it. So, treatment from a medical perspective, like people often need at minimum, like, some sort of like therapy with a mental health specialist who understands PMDD. And then they need, sometimes like a hormone treatment, like we do continuous hormones, because the problem is the ups and downs. So it's like the progesterone that goes up after you ovulate and before you have your period, that's the main issue. So we try and kind of take over and like even that progesterone level so that you don't get the spikes that cause, spikes in the drops that cause the problem. So, oftentimes people get really great relief with just continuous birth control, like without placebos, just kind of going continuously to keep the mood and the hormones more even. So people are like, oh my God, it was like night and day. Like they had been almost to the point of like wanting to hurt themselves. And then they're like, oh, this was incredible. Some people, it's so severe that you actually have to put them into medical or surgical menopause, like that their medications that we give, like Lupron, which is an injection to kind of take over and shut down the system, and basically induce like a temporary menopause. And if that works, then sometimes people are like, they've tried everything else. They've tried therapy, they've tried birth control, like they've tried all of it, and they're just still so debilitated that some people, it's rare, but it's some people actually need their ovaries removed. Like they just need to get the ovaries removed and then go on like an estrogen patch or something to kind of give them some sort of even hormone. And that actually is effective treatment. Again, that's fortunately very rare, but just to say that there are some people who it is quite a process and they, have a lot of difficulty. So anybody out there who has friends, siblings, parents, children who have PMDD, just having the support of loved ones is very important. And also, giving them some encouragement, like if they try one thing and it isn't really working, not to be too discouraged that they may need to see different specialists, try different things, but that there is hope that you can control these symptoms at some point.
Where would you start if you had, let's say you had a child, since we're talking about young people who
Yeah.
are in school, who was experiencing either severe PMS or what you think might be PMDD,
Mhm.
what would you do? Gynecologist,
Yeah,
adolescent?
both the gynecologist and the mental health professional, I would say at the same time. So, in general, if someone is to the point of like feeling they're going to hurt themselves, go to the mental health specialist first. Of course, I tell people like anytime your life is in danger, that becomes priority number one, no matter what else is going on. So, I say that obviously, if it's that severe, you're having thoughts of self harm, you go right to like emergency, like kind of mental health care. And then, if things are more stable, then you also see the gynecologist to talk about like hormone type treatments. So yeah, sometimes it's like simultaneous. Like if I see someone in my office and they haven't seen a mental health doctor yet, I'm like, you need to see one like right now, like yesterday, ASAP. So if that's possible, I know sometimes in different places it's hard to get in with a mental health specialist,
Fine.
but you try and
Yeah.
do whatever you can. So this is where all hands on deck. You're calling the insurance to see who's available. Like you look to see if someone's doing telemedicine. You're getting like word of mouth. Like you're seeing if the primary care doctor or pediatrician can get you in faster with a mental health professional. So you just kind of like do whatever you can to get the care. And so
So we are almost out of time.
yeah.
I want to end with this question about what the biggest misconception about reproductive health is. And I want to do that because I'm guessing, I'm not reading your mind, but I'm guessing that some of those biggest misconceptions are how you chose what topics you put in the book. So my
Exactly.
question for you
Yes.
is kind of twofold. What are these misconceptions and how did you decide? I mean, obviously you weren't writing an encyclopedia and
Right.
you can't cover everything. So
Yeah.
how did you decide what to put in here and what should we take away from it?
Yeah. So, I mean, like in terms of misconceptions, I would just say the big picture of like, that's normal and you just have to deal with it because that is so commonly said about so many of these things. And truly, it's almost like the common thread in like every topic
Women just have to put up.
is, yeah, like people are suffering with it. They're told that it's normal. You just have to deal with it. Not true. So even if something is common, it's not normal, I always say, and you don't have to keep on suffering. And I actually literally tried to include everything I could in gynecology. And I say right in the beginning of the book, there's no way to fit in like prenatal care, childbirth, postpartum. Like there's entire books on those. It would be like, 3 times as long of a book. There's no way to kind of fit all of that. Um, so I tried to focus on like the gynecology aspect of things, which is not the obstetric stuff, but truly like almost everything that someone might have a question about. I tried to have a chapter in the book. So the stuff we mentioned, endometriosis, PCOS, perimenopause, birth control, hysterectomies, sterilizations, vaginal stuff, bladder stuff, prolapse, pelvic floor, all of that. So basically, from every phase of life, from being a teenager, reproductive years, postmenopause, like there's something for everyone and the questions they probably have. So I tried to also address, what are things you might experience, like what are questions you might have, what might be confusing or a myth you might have heard. So we kind of, we did that. And then I also wanted to make sure to include some topics which are like, we say they're political, but they're not. They're medical care, but they become politicized. So abortion, gender affirming care, and gender identity. And also intersex, because intersex people kind of get lost in the shuffle. They get drawn into these conversations about, gender affirming care. Like there's only the men and there's only women, and what you're born with is what you are. And really gender intersex people are like, what about us? Like, yeah, they get left out of the conversation all the time. So, so important to kind of have all of these things to also just like demystify all of this misinformation that's getting promoted in various election debates and things like that. So the book is very much like, here's like the medical facts about things, and to help people to sort out stuff that they might have heard in the news, in social media, questions they might just have on their own. So there's a lot of chapters, but we tried to kind of touch on most of those things so that you could have one resource in one place that you could draw upon, like almost no matter what you could think of. Like, I have a question today about like my vagina or about my sexual health. You can kind of go to the book.
Excellent. Well,
Cool.
this has been an amazing conversation. I think we could have our second and third book club meeting about this
Right?
book because there's so much there. But we have to let you go. I
Of
hear you
course.
might be
I want to
talking
say
about
I
it.
am amazed. Everyone hung in there. Like usually when
Yep.
I do a live or something, you can see the numbers going down throughout the whole thing. I'm like, everybody hung in the entire time, which is like A plus, everybody. Thank you
Even if we
so
didn't read the
much.
book, we still get credit for the book club.
Yeah.
But we're all gonna read it. It's
Yay.
here, and we're all gonna read it as soon as we hang up. And thank you so much. And I know you're on this book tour, so I'm sure we're gonna see a lot of you out in the world. And ASHA will try to include some of your interviews
Oh,
and
thank
put
you.
you on our social.
Oh, I
And
love that. Yeah.
yeah.
And if people like my social media, so Karen Tang MD, I have a website, KarenTangMD.com, but I haven't like updated it with stuff. I also have a Substack newsletter. It's called Gynomite, MIGHT,
Mm,
with Karen Tang MD. And then so
I
you
will
can kind of keep up
subscribe.
with what I'm doing through all of those different things. Instagram probably gets updated the most. And I'll put, where I'm going to be going. I'm going to be going to DC, New York, and then some places around Philadelphia. And it also, I'll mention like places you can get signed copies. I actually just connected with a great bookstore out, near where I am, that they'll ship signed copies to people. It's called Doylestown Bookshop. So it's in my Instagram. Yeah. So if people want to, get a signed copy and support a local, an independent bookstore, that's in my Instagram right now. It's in my link tree as well. And, but otherwise, like, please, like ask your local booksellers and librarians, because the more that we show that there's like a need and an interest in a book, the more they're likely to carry it, to suggest it to others.
Thank you.
And so that's super important to try to get word out there. A lot of people, they may not necessarily have heard of the book, so just somebody calling and saying, actually, like, this is something that a lot of people might be interested in, is really great and very helpful. So
You know what?
it supports the local bookstores and libraries.
I'm gonna make you sign my copy and
Yes,
change the dedication to the fucking patriarchy.
there you go. Yes,
When I see you in person, that is what we're gonna do.
I should do that when I sign books now. Just like like add a little carrot. Be like,
Absolutely.
okay, yeah, yeah, yeah. But all right, great. Yes, yeah, yeah, yeah. And then that's exactly so. The book is written in gender neutral language, just to say, and it also mentions like people who are asexual, like it truly, like, it doesn't kind of make judgments about like it's just like cisgender heteronormative, like so it is intended to be very inclusive, because so many people are traditionally left out of kind of gynecology spaces and discussions. So like I said, I think hopefully people will be pleased by feeling included in the discussion about the book. So cool. All right,
Excellent. Well,
great.
thank you so much.
Yeah,
And
thank you
thank
everyone for
everybody for
coming.
joining us. And we hope you'll come back for our next book club meeting and we'll tell you what book to read pretty soon.
Awesome. Thank you so much. All
Thank
right,
you.
have a good day.